All right, here we go, ladies. It's been a little bit of time since I've interviewed two guests at the same time, so I'm really excited to have a conversation with the three of us, and I really appreciate you making time. Um, so, by way of background, just to introduce how this episode came about, is in December, there were a couple of New York Times articles and opinions written about tongue tie for babies when it comes to moms who are struggling to breastfeed. And I have an expert that I know, and I was like, I need to talk to someone. I want to hear expert reactions to this. I want to have a two-way conversation. I don't want it to be just something I read in the New York Times. And it was really interesting because some experts were hesitant to go on a podcast to speak publicly. So I'm really intrigued to have this conversation. And so, welcome, Victoria and Dr. Holman. So, why don't we start by first introducing yourselves?
Sure. I'll give a little intro of myself and how I found and um, maybe inspired. I'm going to go that far, Dr.
Yes.
Holman, into this work. So I'm Victoria Facelli. I'm an IBCLC. I wrote a book about feeding babies called Feed the Baby. And I was an IBCLC and honestly a little bit of a tongue-tie skeptic. I was sort of brought up in my program very sort of like published research driven. It was a program within a school of public health. So really grounded in that perspective, really focused on like positioning for babies and kind of looking at the whole picture. And I came up kind of in between two waves of pain in breastfeeding. There was one wave of thinking everybody had thrush, so a yeast infection on their nipples, into thinking everyone had tongue ties. So I started as a little bit of a skeptic, finished up school in lots of different settings, went out into the community and became an outpatient lactation consultant. So I was working with folks in their first weeks and months home. And there were some babies that no matter what I did, the realities of a tie were just there. And so I would then refer to ENTs or dentists to correct the tongue tie, sometimes midwives. And I was shadowing everyone to these different places. And it just, like, they needed this care and it was better after, but I just didn't love the way it was happening. Like the care directly to the parents just wasn't where I needed it to be. And then the other piece of this work that I was seeing that was so important was really looking at the baby, really looking at like, is this like, I'm looking at, could this be a different low supply issue? Could this be thrush? Could this be a positioning thing? But I also needed someone really looking at that baby, looking at patterns of tension, doing that. So I was working with a body worker, but I just didn't feel like I had deep trust in the providers that were actually doing the procedure. And so I sort of like made it my mission to find somebody who would work in tandem with different providers, but also who I could really trust. And so I ended up just in a random Facebook group and saw this dentist. And I was like, well, at least you're a woman. Like, let's just start there. And so Dr. Holman was just starting her practice, and I marched in there and I was like, look, here's the thing. There's these tongue ties. I really like need someone with ethics to do this. And Dr. Holman was like, oh yeah, I like do those when I volunteer in nursing homes sometimes. And I have this PhD in infant suck physiology and breastfed 2 kids. So sure, let's go learn about that. And so that is how I met Dr. Holman. And now I will let Dr. Holman introduce herself.
Please. I love
Welcome,
that. That's
everybody.
awesome.
It's exactly how it happened. It's so funny. I was starting my practice from scratch, and she approached me along with her friend, a massage therapist that works with babies, and they told me some of the problem and what they were looking to do. And I'd used lasers before. I've done frenectomies and frenuloplasties before, but not on newborns, on older people, because the other reason you sometimes do these are for dentures.
Ooh, I didn't know that.
Yeah, so I had, and then I had my PhD was all in the role of sensory information during infant suckling. So I had this background in that, having breastfed myself. And so I felt like I had all the pieces. I just kind of didn't know how to put all that together to help her out. So I started taking some classes and then got really inspired by that. And we started building this multidisciplinary clinic in my office. So yeah, my undergrad degree was in anatomy, like evolutionary anatomy. And then I did my PhD work was in biomedical sciences, but my dissertation was all about oral sensory information during suckling using an infant pig as a model to better understand infant humans. And then I did my dental degree. Those were both at University of Maryland. My research was at Hopkins. And then did a residency program to do more advanced dental surgeries and dental work. And then I moved back home, which is Chapel Hill, North Carolina, and started this practice from scratch.
Yeah, so we went, the three of us, the body worker, myself, and Dr. Holman, to go train, to go to a conference, really specifically delve into this work with infants and look at it from a functional perspective. And then because we all have that research inclination, even though this is very difficult research to publish, which we can get into, we have had such a curious mindset and have really thoughtfully and carefully evolved the way that we practice. And so when I wrote about tongue ties in the book, right, where I'm generalizing, Dr. Holman isn't everyone's surgeon. Not everyone is in Chapel Hill, North Carolina. So that's where it connects back to the New York Times for me, where I really had to sit in like, okay, if I don't have Dr. Holman in front of me, what is the recommendation I'm going to give to parents? And so this is where I think the New York Times got it wrong, was really looking at a few cases of probably malpractice, or at least like not deeply thoughtful practice, which you'll find in any area of medicine. And then to look at the research, but not talk to those of us in the field that interpret the research, which is to say that it's very difficult to be like, I'm going to mess with this baby and see if it stops eating and not mess with this one, right? Like that's what it would take to do a double blind. And that's not ethical. You're never going to get IRB approval to do that ethical research. So it is really challenging to research. And so my recommendation has always been like, really look for functional assessment, really look for providers that you trust, and then really listen to those providers directly. And so I think we can tie all of this back in, and I want to backtrack and really talk about like what a tie is, but I think that really like gives you an understanding of how we work together and why Dr. Holman is unique. And part of that is her respect for the body worker and the IBCLC.
I'm really interested in this because I also had struggles nursing. And, I'm thinking like, first, I just want to say, Victoria, your book is awesome for those who are going to watch on YouTube. This is the US cover. And what an amazing book. What I loved about it is you're so fair and balanced in all the options. The book is called Feed the Baby, an inclusive guide to nursing, bottle feeding, and everything in between. And I completely agree. That's exactly what it is. And you cover everything from how to pick different types of products, what you need, what you don't need. You talk about the myths of formula and the marketing versus what you really need. Like all those nuances are in this book. And I think it will help people be empowered in choosing what is right for them. Yes. So I had to at least give that praise. So, as someone who was struggling and, this was, my son's 8 years old now. So 8 years ago, I feel like even since then, I've learned so much more about women's health. I feel like there's so much that's changing. And, when you're in that struggle, what is it? And I think, just like with my fertility journey, when you're struggling, you'll do anything. And it's so hard to know who to trust, how to know what to do, etc. So I guess, Victoria, I don't know if maybe a good place to start, you're the expert here, but like, what is the baseline that we start with? Because at some point, tongue tie becomes a part of the conversation. And so I don't know if you want to put into perspective of, because I don't want this to start from, should I do tongue tie, yes or no? And let's answer that in the podcast. Because to me, the question is, babies struggling, oh, tongue tie might be an option. How should it, you know what I mean? So I'd love your thoughts on that.
So one thing I always want to bring up is that ties impact oral function. So they impact how the tongue and lips move together. And that can appear at different functions at different points along life. and with different tools. So we actually have a good number of babies that nurse beautifully. No one's in pain. Milk production's fine. They're gaining weight, and they absolutely cannot take a bottle. And some of those babies can't take a bottle because they have a tongue tie, and nursing is actually easier for them. We also have babies that nurse just fine. We'll often get younger siblings in the clinic, and the older sibling is tongue tied to all get out, but nursed fine, and now is struggling with speech or struggling with snoring and sleep apnea, but they were fine with nursing. And we also have some that looks like a tongue tie and it doesn't impact function at all. And there's going to be no issue until they get to a nursing home and need dentures and they need it revised then, right? So like, we're not just looking at this piece. And that's part of why I love working with like a family dentist that really sees the whole lifespan, I think is really helpful, that we're looking holistically, we're looking functionally. So when a baby is born, there are very few things that human babies can and need to do when they're born. We have just like these very immature, kind of dumb babies, and we love them and take care of them with our big brains, our opposable thumbs, and our many tools. And so one of the things that they need to do is eat. And in order to eat, it's actually pretty complicated. And this is where Doc's research in pigs is so interesting, because pig suckling is so similar to human suckling. And just like we said, the ethics are complicated. So that does change with our current science model of doing an animal model versus a human model, right? So with a baby, they need to, in order to do a suck correctly, get their tongue all the way past the gums. While it's past the gums, cup, so curl up the edges. And then while it's curled up and over the gums, drop the back all the way down to make a vacuum. So babies don't, I would say, like, it's not like drinking out of a straw, it's like eating a taco, right? Babies nurse and ideally bottle feed with their whole mouth, using mostly movement at the back of the mouth, and the front of the mouth is actually just making that suction cup. And so you need a lot of that ability for the lip to flip and the tongue to curl and reach to make that shape. Babies are like, I'm going to eat. I'm going to survive. And parents are like, I'm going to feed this baby. So if they can't do that, what often happens is a lot of pain because they're using the wrong muscles. And so they're doing a chewing motion instead of that vacuum motion where they're dropping at the back of the tongue. Instead, they're going to be doing more of a chewing motion with the front. So some things that we're looking for initially are you in pain? Is baby gaining weight well? Are they, if you're doing bottles, are they able to do a bottle without coughing or sputtering or it taking an hour to do a bottle? If you're nursing, does your nipple come out looking flat or with a straight line across it? And then your first step is going to be talking to a feeding expert, a lactation consultant, to figure out, like, is this a positioning thing? Is this like they don't know how to do it and we can sort of use tools to teach them? Or is there an actual structure that's causing an inability to do that? So everybody has a frenum under their tongue, which is the little piece of tissue that attaches your tongue to the floor of your mouth. And there are more of them throughout the body, including one right under your lip, right? For those on YouTube, right under your top lip, under your nose. And so if either of those is very tight with collagen that doesn't stretch, which is genetic, it's going to potentially cause issues with function, either with eating properly, eating solid food properly, closing your lips while you're sleeping and at rest, or speech and those other issues that we talked about later down the road.
Okay.
When a baby's nursing or when a baby has a tongue tie, it's very common that when they can't use their tongue very well, that their upper lip muscle gets really, really active. Like that upper lip is trying to create a seal that the tongue is not doing. Yeah, the tongue can't do it, so lip gets really involved. So we tend to see this upper lip completely curl under and dimple and just be really tight. But that's not always because the structure itself is tight. It's often because the tongue is tight. The tongue isn't doing what it's doing. And once we get the tongue tie release, this upper lip can flare out and relax and get out of the way. So I find that sometimes buccal frenums feel very prominent when I'm doing an exam on a baby. and then after a tongue tie release is done, or even that midline lip is done, I don't feel these anymore. They relax once that muscle is relaxed. So I think they're a little tricky in that way.
And I think that speaks to that like bigger function question, right? That we're looking at like tension in the neck, tension in a baby's body. And some of that can be from birth or pregnancy, right? We grow babies in a tiny bowl. They need some space and time to stretch out. But also this piece, I think about it like rock climbing, that like if you're up on the wall and you're like in your big muscles and your legs, your hands and your fingers aren't doing all that much, right? It's the same with a baby's lips should not actually have to be doing that much. They're mostly just making a seal. But if your tongue can't move correctly, then you're going to do something. So you're all what I call grip and grab. So they're going to be overusing that muscle. That muscle is going to get really big and overdeveloped. And then it's going to look like tension against the other muscles because of how that baby's eating. And so that's where I push back on the New York Times article, which didn't get into like, did they have an in-depth functional assessment? Like when someone comes into our clinic, and this isn't available everywhere, there is a body worker that's actually doing hands-on massage therapy to release tension throughout the head and neck so that Dr. Holman can get a good visualization, but also so that we've ruled out that the issues aren't being caused by that kind of tightness. Then I'm watching a baby eat and I'm really looking at like, what muscles are they using? Are they correctly trying to use the right muscles? Do they have access to them, but they don't know how to use them? Like, what does that look like in terms of actual function? What does feeding look like throughout the day? Maybe this feeding in front of me is great, but they take usually 2 hours, right? Like that's all information that I'm looking at. And then Dr. Holman does a very thorough physical exam where she's looking for those buckles. She's looking like, what are thick muscles? What is tension? Because I don't know all that much about the anatomy of the mouth, whereas Dr. Holman knows a whole lot about that.
If the buckle ties need to be released, what I hear from my lactation and SLP colleagues is that when babies have the lip, tongue, and buckles released all at once, those babies tend to struggle a lot post-release. Much more so compared to just doing lip and tongue or just tongue. So if I question the buccal frenums as being maybe they are kind of tight feeling, like I don't know that those are going to completely relax when everything else is done, I still will intentionally delay that release and say, let's do the lip and tongue first. We know that's going to improve things a lot. And if it still feels like there's just too much tension over here, let's give this a week or two. Then I can release that at a separate time once baby's kind of recovered from these 2 wounds.
Right.
Again, that's really hard to demonstrate in the research, right? That's going on clinical practice. That's going on talking to other people. And that's in our practice, you're going to say to that family, I am noticing these buccal ties, which by the way, buccal, buckle, dentists say it buckle, but other people say it buccal. So if you're confused, we're talking about cheek muscles. That, Dr. Holman is going to directly talk about that and say, we're watching it. Here's why I'm not going to address it now. Do you have questions about that? Here's when you're going to come back. We're not going to charge you again if that's needed, right? Like, and that's deeply ethical practice because it would be cheaper and easier for Dr. Holman to just do it all at once. And that's where you do see variability provider to provider.
So can we take a step back then? Because I just want to make sure I'm not misinterpreting. So part of the controversy is that it seems as though there are cases where it may appear moms are being taken advantage, I should say families are being taken advantage of. I guess I'm just saying mom because she's doing the nursing, but families are being taken advantage of by having procedures done that are unnecessary. And what I want to clarify is originally when you were speaking, Victoria, about how, there could be different stages in life where the tie can have an impact. I guess one thing I was wondering is because of that potential, should everyone have it released so that you don't have the things down the line? Or is it, but also there was the nuance of not everyone is going to be affected. And so I guess I'm now curious around this whole, like, does it need to be done in all cases? How do you know when?
I can speak to that.
All those things. So can you help me understand that?
And it is confusing. And that's why this isn't just like, it looks like this, these are the symptoms, this is the recommendation. And a lot of research studies and tools out there try to simplify this into like a formula with an answer, and it's just complicated. So sometimes when the three of us do our assessments on these babies and step out of the room to discuss, sometimes we look at each other and go, that's a tongue-tied baby. This is going to help. We're all on the same page. And then we come back and it's just really straightforward. And other times we're like, I'll say, it looks kind of tight. And Victoria says, that might be part of the issue, but part of the issue might be this other thing. And then our massage therapist says, well, there's also some signs of torticollis that could also be playing a role here. And sometimes we have to really scratch our heads a little bit and talk to each other about where do we even start here?
Okay.
And if a tongue tie release is part of this puzzle, is it best to do it now? Is it best to do it even if it doesn't make an impact because I'm pretty confident it's going to lead to other problems later on? That's sometimes part of our conversation.
Okay.
And a lot of times we will come back to a parent and say, this frenum looks tight and looks like this could be likely to lead to other problems. And we do recommend releasing it, but we don't know that a release is going to fix your current problem because of these other factors. So sometimes that is kind of our conversation.
Okay.
We've even had babies, including my own. My child number 3 was a situation where mom's not having any breastfeeding problems. Weight's good. Feedings are quick. No gas, reflux. I mean, they're managing through. Usually that's because mom has a pretty darn good supply and baby's doing something like a suck, and it's just not, there's no major flag or problem. But if the tongue frenum is really, really tight and right behind the tip of the tongue, and when I test reflexes, those reflexes are not showing me great range of movement, and maybe I can see some subtle other things, which I can go into. Sometimes the recommendation still is like, look, this is such a minor procedure, and the chance of like this tongue tie that's almost to the tip of the tongue causing some kind of problem down the line is certainly high. And that's, again, not to say a parent has to do something right then. Some parents are a little bit more like you're saying, like, if this is going to cause a problem in the future and this is such an easy procedure to do now, I'd rather do it now. I have other parents that are like, I'd rather take the watch and see approach, and let's see if we have a problem, we can address it then. So in those cases, I try to talk through what that would look like, That might mean, let's see how solid foods go. But around 6 to 8 months, if solid food introduction is not going well, and a speech therapist is now involved and it's because the baby cannot move their tongue, we can still do a release pretty easily at that age.
Right.
But part of that conversation I try to address with parents is that when a kid is about 1.5 to 4, this is now holding down a toddler, which is not fun for anyone involved, parent or me. Could lead to oral aversion if you have a wound in your mouth at that age. It'd be very difficult to do the wound care instructions after the procedure. Some parents even do general anesthesia for this procedure at that age, which I don't love because that's not zero risk. It's low risk, but not zero. So I try to also explain to parents, like, this is a good thing to try to figure out how you feel about it and how it's maybe impacting things now. Or else, like, once a kid's over the age of 4, we can get them with the speech therapist. They're going to have to do a lot of myofunctional therapy, work on strengthening these muscles. There might be obstacles now in play, but it can still be addressed. It's not like too late.
Okay.
I do frenectomies on adults that are having issues. So it's not like it can't happen. It's just that we're now usually involved with speech therapists, feeding therapists, trouble swallowing. Like, there's things that we're now working to address.
Right.
And it can be tricky as the provider, as the dentist, to try to explain to this to parents, because I don't want to be driving fear in someone, saying, like, if you don't do this, all these horrible things are going to happen. Because I can't say that. I don't have the crystal ball. But I do try to talk through, like, if the baby's already maybe not having any feeding problems, but the baby is snoring and sleeping with their mouth open, that starts to worry me about development of sleep apnea. Like, that's a thing that leads to bigger things that makes me a little, maybe push a parent more towards, I really think this would be a good thing to deal with now versus later. Versus a baby that truly has no issues at all.
Right.
That's pretty rare if they're already in the office, but that happens sometimes too, where I'm like, I can't reasonably think of anything that I feel somewhat confident that would happen, I think it's better just to watch and wait. And,
Right.
we do have that reputation in our area. We will be very clear with parents if it's better just to watch and wait. And there are parents we say that to all the time, that like, look, this is not a big enough issue. It's not visually tight enough or there's no symptoms at all. Like, just wait.
I agree with you. Like doing things late is so hard because you have all those added layers. And again, I'm not trying to scare parents, but that proactive thing is so important.
There are chiropractors who do this work. Chiropractic care on infants looks very different from adults.
Yes.
It's
Yes.
very slow, very gentle. It is about the amount of pressure you use pushing a piece of paper across a table. Very, very gentle. That being said, again, just like there is with dentists treating tongue ties or lactation consultants, a wide range of practice. We very aggressively vet our referral list. Here are some people in our area that we know and trust. Here are some pros and cons of the ways they practice because we know them. Here's a list of massage therapists that do similar work, albeit more slowly because of their different scope of practice. They may or may not be close to you. They may or may not be covered by insurance. Here's that information. And then we also in our area have 1 or 2 pediatric osteopaths, which are similar to MDs, but also do manual therapy. And they're much more common in Canada. And actually that's like the one double blind I do have is there is a double blind trial of osteopathic hands-on manual therapies. Also, PTs will do this manual therapy as well as functional therapy. And so in the study, it's osteopaths because it's a Canadian study, and they did pretend body work on half the babies and actual body work on half the babies that were having suck dysfunction is how they defined it. And it did make a statistically significant difference. So like there is, albeit a small evidence base for that, but that's about all we ever get in lactation anyway. And that's, again, this question of like the risk benefit, right? Like risk benefit changes over time. The risk of holding down a 2-year-old to do this procedure that then means they fear the dentist
Right.
is a much greater risk, even though it's the exact same procedure. That's an added risk that we don't have with an infant, that like it's 30 seconds, it's 2 minutes away from their parent. There's a very low risk of bleeding with a qualified provider who is skilled with that tool, right? That looks different. There is still some risk. We have had a handful of babies that had trouble figuring out how to eat after that. It's pretty rare, but it happens. There are risks to everything that we do. And that's something I talk about in the book, is that you get to decide holistically in your household. Like if somebody's having just an absolutely horrible time and they're up all night and their baby takes so long to eat a bottle that they never, ever, ever get a break and their baby's miserable and they're miserable. And I'm like, it's a coin toss if this is going to help, like from our assessment. The benefit of ruling it out may be much higher for them than someone that's like, he's a little gassy, but it's like not that big a deal. We might wait and see in that one. So I think that's one of the things I pride myself on is we really trust our parents to be collaborators with us. I always tell parents to look for curious providers. We're very curious about what we're doing. We do approach folks with like, these are the symptoms we're seeing. This is what concerns us. This is what doesn't concern us. These are the options. If it's a really clear-cut, strong recommendation, which I would say in our case where our referral chain is pretty effective, is about half of our patients are really straightforward and about half are complicated. And that's not to say the tongue tie is not indicated, but in those more complicated cases, I mean, it's always a conversation of like, this is our recommendation. We'd love y'all to talk about it, learn about the procedure, decide what you want to do. But in those more complicated cases, we're really going to talk about like, here's how far we think body work might get you. Here's how far we think lactation might get you. Here's how much you should expect to have to do in terms of therapies afterwards. You know, like we feel great about the fact that your baby's mouth is closed when they're sleeping, or we feel worried that your baby's mouth is always open. We're concerned about the shape of the palate because of XYZ, or Dr. Holman might be like, you're not having a nursing issue, but that is going to cause a gap between teeth, which could cause cavities, so that parents get to do the risk benefit based on the way that they view risk.
I will say one thing I tend to see a lot, because I see people through the ages, is I tend to hear a lot from parents that they were told or under the assumption that the tongue tie was only important if you were breastfeeding.
Ooh,
That
that's a really
as
good
and
point.
that they felt that they were selfish because they wanted to breastfeed if they made that decision to do a tongue tie release. I hear all the time from the older
Yeah.
kids.
Oh, that's
And
heartbreaking.
they felt like nobody really explained that some of maybe the GI issues they ran into with bottles, or their kid is now in speech therapy, or has a lot of issues eating solid foods and only like softer foods and no textures. Like they had no idea about that kind of stuff. And then to see how quickly some of that stuff turned around after a release in their older kid has them feeling not great about, some of the other struggles they had before that, like feeling like they could have prevented some of that stuff too. So
Right.
again, I think, that's not everybody's story, but that's what I tend to hear more so about, is people just being like, I had no idea this related to how my kids' jaws would develop and how straight their teeth would be and how they would do all these other functions. I really thought this was a breastfeeding thing. Or they say, my pediatrician said my child was gaining weight, so I had nothing else to worry about. And I thought as long as my baby's gaining weight, they could be. I've seen 5-year-olds where the tip of their tongue is connected behind their lower front teeth, like that, tied, like can't eat hardly at all.
Oh
And
my
they were
God.
told like, don't worry about this as a baby because the baby was gaining weight, or because the baby was,
But
taking box. So
saying
like,
like they're not going to sleep well, they're going to snore, you're going to need speech therapy, it's going to interrupt their digestion, like blah, 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 all the way to dentures can be fear mongering to new parents that are really fragile.
right.
So like that's really where the
It's
balance
tricky.
is like in that piece. First of all, like lactation, I've never met a lactation consultant taking kickbacks from dentists. If that's happening, that you should have that conversation with your lactation consultant. I am paid for my time assessing babies and working with babies in Dr. Holman's care, but it's like very transparent.
And dentistry, by the way, also is profitable without needing to do this procedure. Most
I
dentists
would
will
say this
say,
is probably one of the less profitable things you do.
and people are like not very interested in doing this, like in
It's
general.
not
Like
that interesting. It's not
more
that
exciting to like learn how to
complicated.
place an implant or do
So what?
something
Yeah.
exciting
So
versus this. This is not. This is, you do this because you really love it, not
It was
because
really made out to be this like
profitability.
money grabbing thing that certainly has not been our experience.
okay. Now, one of the things they also talked about was the clipping versus the laser, and
Yeah,
how there's a push to do the expensive laser, but it's really not needed. Like, so let's say the decision is it's time to do it. Tell us laser versus the traditional old
so
fashioned clipping.
as far as expense, I think that's going to really vary based on people's experience and their insurance coverage, because it might be, there's some medical insurances that only cover this procedure if a medical doctor does it. If you have dental
Oh,
insurance, they're going to almost cover it in full, you know?
got
So
it.
like it totally depends. And some dentists bill medical insurance. Like that's what we do here. So
What I say like to everyone, because I'm not a dentist, I don't have a dog in that fight, is find the most skilled, reputable provider that you can access. This is a one-time thing. If it is possible for you to cover the cost, find the provider who's going to do the best job. Now,
I've seen some really awful scissor releases, and same with laser. I think what makes this procedure hard as the dentist doing it has much more to do with the diagnosis methods that the person is using. And then also there's the tool and the actual procedure. But I think where you see a very big difference between providers is how they are doing the assessment. I've spoken to many dentists and ENTs that just say, the lactation consultant told me there was a tongue tie, I released it. What's the big deal? They don't like, not factoring anything else into the equation, or really doing an assessment of reflexes, or really thoroughly looking at making, like, as the doctor, we are the ones that make the diagnosis. A lactation consultant cannot diagnose a tongue tie, or that this tongue ties.
unless they have
They
another
cannot diagnose.
credential. So if they're a speech therapist and a lactation consultant, or a nurse practitioner and a lactation consultant, they may be able to. Myself, that's my standalone credential. I do not diagnose tongue ties. I assess for function and I refer to Dr. Holman.
Okay.
Right. So if your release provider has no methods of doing a diagnosis, that would be a red flag. But I think a
Okay.
lot of the part that was skill wise hard for me to learn was that the diagnosis and really feeling confident that this was it. And there's the obvious ones where it's like to the tip of the tongue, where like obviously the baby can't move their tongue, but when they're subtle in their appearance and there's a lot of other factors going on too, that diagnosis is really hard to make.
Yeah.
And then with
Dr. Holman, would you say it's the same possibility of like making a mistake? Like to me, I'm like under a baby's mouth is like tiny and is crazy in there. To you, you're like, that's very obvious where the salivary glands are. Like only a like absolutely untrained wingnut would miss it because you're really, really skilled at what you do, which is why you should do what you do. But do you feel like there is more precision with the laser than the scissors so that there's a theoretical lower risk?
So I guess that answer is so, I go into minutia here. So I feel like there's a lot of things I do during the procedure there are a lot of things I do for a reason because I think I get a better result, and I can't speak to other people, of course. But a few things about that. First, I'm 7.5 times zoomed in for my eyes. So in my field of view is humongous down there. It's not so tiny. There are release providers that don't wear magnification when they do it, so that's a difference. I also use a groove director, which is a tool that isolates the frenum very precisely and kind of pushes on either side so I can really get a good release that way. Again, there's other people that use a finger or don't use any tool to isolate it. So to me, that gives me a certain level of precision.
Can you discuss the costs?
I have patients that everything's covered 100% by their medical insurance or dental insurance and pay nothing. I have other parents that pay a small copay, like towards a procedure. So it really ranges. For people that have no insurance at all, we just have a flat rate fee that they pay that covers their follow-ups, any amount of releases that are needed. The exam, the lactation, the body work is just kind of a one lump sum fee. I think those fees range from maybe $600-700 to maybe $1,500 in different states and practices.
Okay.
And there's going to be also variation in Medicaid coverage.
Medicaid.
Wow, right. So here's a question then. I want to ask from two perspectives. So one, we're finally seeing that, I don't know the nuances, so I hope I'm even saying this correctly, but Medicaid is really starting to, I'll just say they're recognizing the importance of having doulas. Okay. So that and the other, but I would like, let's pretend you're the committee, the body worker, the IBCLC, the dentist with the PhD, and you're talking to the payers and you're like, here is the value add of covering team-based care for these babies. Like, what is the cost down the road if we don't look at this today? So I don't know who would want to answer that question. And then I want to ask for a question for the parents, but let's start with the business side of healthcare. Gosh darn it.
Yeah, I think the business side is kind of similar to the doula arguments. And you're just if you're trying to save Medicaid money, you're going to save Medicaid money if the baby's breastfeeding, because you're not going to have to pay as much towards the formula. Like there's other more support
coverage in those pieces.
Exactly. There's going to be a lot of
women
other
still have the
government
right
funds.
to choose. So women still have the right to choose. But
Also
for those who want, yes,
also,
continue. Yep.
They also need to understand this affects how babies feed from a bottle. So it's also going to reduce their long-term costs when these babies have GI problems and need a lot of GI follow-up. If this is
needing a speech therapist.
Yeah, absolutely. Yep. There's also the long-term thing. Again, if you're going to need speech and language pathology services, OT services, PT services, all these things we see these kids end up needing, that's where they can really save on that cost. By having access to these three things would give you a better diagnosis or a more confident diagnosis or thorough, which will lead to the best treatment, which again may or may not be a tongue tie release, but would help reduce the long-term burden.
But it might be an early referral to a physical therapist, which then down the road saves the cost and struggle of a helmet.
Yes.
Got it. Okay. And I can attest to all this. My son is 8 and we are getting the results from his first OT appointment tomorrow. And so, that's like our next journey, because round 1 of the challenges were solved after 4 years of lots of doctor appointments and procedures that could have been all avoided had we had the right cross-functional team of experts. So I echo everything you are saying. Now for the parents, and by the way, what I always look at this podcast as is we need to be as informed as possible to have the right conversation with our clinical care team. And, you see these doctor appointments, and I think a lot of people are well-intentioned. Most are well-intentioned. I think people are busy, they're human, and mistakes will happen, and maybe not always the right conversation, which is why we need to be informed to advocate for the doctor who may have had something overly busy that day and forgets to bring up something that kind of could have changed the appointment. So for the parents, I would say there's two categories. Ones who are like, I can't afford this. So what is the minimum? Like baby massage? Is there a book? I don't recall if you had exact baby massage instructions in here or not in your book, Victoria. But like, what's the minimum for parents who are like, I can't afford all this stuff. This is great. Thanks so much. I don't have that kind of money. And then for the parents that do, I think you kind of alluded to already throughout the episode of things to look for, but maybe there's like one or two big things. So parents who can't afford, parents who can, maybe two buckets there on your top recommendations, the must-haves.
So a tie, like that actual structure under the tongue, it doesn't stretch. It's not going to change if we don't release it. So in that case, it would be talking to your insurance, talking to local providers, figuring out where you can get the best coverage that is accessible to you. Some providers, I think increasingly, are working really hard to make that happen. And that means that some of our parents are driving really far to get to us because we are able to see them. And we work hard to do that. It takes a lot of Dr. Holman's team to run that medical billing side of things. It's not straightforward. But it's ethically important to us for access. So I think number one would be really like if there's an actual tie and the people around you are saying this is a tongue tie, then for that piece, seeing the provider that is closest to you, that is financially accessible. Okay. Then after that, in terms of the body tension piece, if you're not able to see a lactation consultant, though many folks who are lower income are able to see someone through WIC. Yep. Increasingly, lactation consultants do take insurance. Some are able to do online via insurance, again, because of increased Medicaid coverage, thanks to the work of one of our amazing local IBCLCs and editor of the Journal of Human Lactation, Ellen Chetwin, for her doctoral research, actually drove that forward. So amazing. We're just a little family of nerds over here in Chapel Hill. But
my son was born in Chapel Hill, and it was the most amazing community. I think I literally was in Chapel Hill for his birth, for the most amazing birth ever. Like he was born in 15 minutes, but it was still amazing.
It's a pretty special place. We've got a lot of universities. We've got a lot of interesting dorks around here. Yeah. So I think similarly, is there a way to access lactation care in that way? And then in terms of the bodywork piece, many body workers do have sliding scale or do have drop-in times through a clinic for lower income folks. And then in the book, there are some stretches and rolls into tummy time. Tummy time is a big part of this. Because if you think about if you stretch your body into that tummy time position, that really stretches all of that tension. So if that tension's coming from a piece of tissue that doesn't stretch, nothing's going to change that. But if there's tension in these muscles from compensating for that tie, once we get rid of that tie, that stretch is really important. So things like tummy time, rolls into bodywork, physical therapy, which is much more likely to be covered by insurance, would all be good options if the bodywork is out of reach or the kind of integrated clinic isn't available in your area.
Okay.
Yeah, and then as the provider, asking about payment arrangement options. Care credit is a popular one that a lot of patients use to help pay for any dental expenses that are foreseen. Care credit allows you to make interest-free payments over the course of whatever period of time. Interest kicks in if you spread it out over a long period of time. But that can keep payments down to $50 a month or something like that. So if that is an issue and you want to get it done, just asking those questions, ask about the insurance coverage, try and do a little digging on that.
Okay. Awesome. Well, I really appreciate the two of you making time. It was a really interesting article. I had no idea it was like this issue. So I don't know if the article made it that, or if it was really something that has been kind of um, under the layer. But nonetheless, I'm glad it came out, because I think at the very least, I got to do this interview and help people understand there really is this cross-functional way to look at this. I mean, I went through the experience. I was in an amazing community, and these nuances, I mean, I was stressed out. So maybe they did bring it up. I have no idea. I don't recall. Um, but the world keeps changing, and we're learning so much more, and cross-functional is the way to go for everything. And it's great to see what you're doing. And now let's see if the payers can see the value as well. But I'm sure everyone got so much out of this episode, and thank you for your commitment to really digging into this with all of your patients.
Thank you so much for having us. We really love this work. And like I said, we're giant nerds. So we also really love talking about it and sharing about it.
Yes, thank you so much. And, both of us are on Instagram and love engaging in discussions and giving our 2 cents on things. If you guys have questions, reach out.
Awesome. And I'll put all the links to be able to access you and reach out to you in the show notes. So please, everyone, check that out as well. So thank you again so much. I really appreciate this. Have an awesome day.
Thanks.
Take care.